Bismillahirrahmanirrahim. Today we will discuss complications associated with suppurative titus media. By the end of this lecture, we will solve this scenario. And I have told you that complication of suppurative titus media, we divide it into two types: extracranial, that are intratemporal complications, and intracranial type. So recall anatomy of the middle ear. Roof is formed by tegment tympani. So whenever there is erosion of the tegment tympani, infection will involve the intracranial cavity. If it is outside the dura, it is called extradural abscess. If it is inside the dura, it is called subdural abscess. And there then will be inflammation of the meninges, that is called meningitis. Then intracerebral abscess formation, and then lateral sinus thrombophlebitis, endotitis hydrocephalus. So all these are the intracranial complications. So what are the routes of spread? Bone erosion due to hyperemic decalcification in cases of acute suppurative titus media, due to pressure necrosis and inflammation in cases of chronic suppurative titus media. Because of absence of valve in the veins, there will be venous thrombophlebitis, and infection can go directly into the brain. Then preformed pathway, that is congenital dehiscence in the brain base of skull. Then patent sutures, surgical defects, any history of previous surgery. Then anatomical phenomena, that are in internal acoustic meatus, acute act of vestibule, oval and round window infection can go into the intracranial cavity through these phenomena. Then infection can also involve the intracranial cavity by means of blood, by means of hematological spread. So it is really seen in cases of non-autogenic diseases. So intracranial complication can also be due to some non-autogenic diseases such as nasal diseases. Then there may be some neural involvement due to viruses. Then hematogenic, then through blood bacteria can enter into the intracranial cavity. So what is extradural abscess? That is the collection of pus between the bone and dura. You can see collection of pus between bone and dura, and it is seen in at two places. So it is seen in the region of tegment tympani, or can be seen in the region of sinus plate. So it is really seen in subacute, acute, and chronic infections of the middle ear. Usually, it can remain asymptomatic and discovered accidentally during the surgery. But patient really have patient really comes to you with the history of pain in the ear. Chronic suppurative otitis media itself is the painless disease, but in this, patient will come to you with the history of earache. So, extradural abscess can involve middle cranial fossa, dura of the lateral sinus in the posterior cranial fossa. So, tegment tympani, if there is erosion of the tegment tympani, middle cranial fossa will be involved. If there is erosion of the posterior wall of the mastoid, that is perisinus, that is sinus plate, it will cause abscess formation along with the sinus. So it is called perisinus abscess. So extradural and perisinus abscess, what are the clinical features? There will be persistent headache. Patient comes to you with the history of chronic suppurative otitis media, but there will be pain. As I have told you, chronic suppurative otitis media is painless disease. If patient comes to you with the pain, it means there is some complication is developing in this patient. So there may be low grade fever, malaise, anorexia, and pulsatile ear discharge, because dura move with the pulsation, so there will be pulsatile ear discharge. Then investigation, You will you will examine the ear under microscope, you will send pus for culture sensitivity, and you will advise CT and MRI to see an involvement of the bone, and their extradural abscess will be clearly visible on the CT scan. So antibiotic is given, but immediate mastoid exploration is required in these cases. If it is due to acute suppurative titus media, then cortical mastoidectomy and drainage of the abscess is done. If it is chronic suppurative titus media, then canal wall down procedures can be done along the aspiration of the drainage of the abscess. So you can see in this again we call dura. Beneath the dura is the subdural abscess, and beneath the in between the bone and the dura is the extradural abscess. You can see intracerebral abscess in the brain, in the cerebrum. So temporal lobe and the cerebellum are usually involved. The subdural abscess, collection of the pus between the dura and arachnoid. So clinical features are the features of meningeal irritation. There will be raised intracranial pressure. Patient will come to you with history of chronic suppurative titus media, but now he has developed pain, and ear discharge may be pulsatile, and there will be fever, malaise, anorexia, drowsiness, neck rigidity due to meningeal irritation. There will be neck rigidity, positive curling sign, that is inability to straighten the leg when the hip is flexed. Then if there is raised intracranial pressure, there will be papillary edema, and if there is paralysis of the third cranial nerve, there will be ptosis and dilated pupil at the site of infection. So third nerve paralysis is common in these cases. Other cranial nerves, fourth and sixth, are usually involved. Then there will be aphasia. Patient will unable to speak. Hemiplegia of opposite side, hemianopia, and epileptic fits can be seen in these cases. So investigations are same. You will examine the ear under microscope. You will send pus for culture sensitivity. Then CT, MRI, and lumbar puncture is done. Lumbar puncture will show increased protein and low sugar level. Then treatment is again antibiotic. You will treat the intracranial complication. Then you will advise mastoid exploration. So you will send the patient to neurosurgeon, and along with neurosurgeon, you can perform burr hole craniotomy, and then later on mastoid exploration. Then meningitis is the inflammation of leptomeninges. Leptomeninges are pyometer and arachnoid matter. So clinical features will be due to irritation of the meninges. There will be prolonged history of chronic suppurative otitis media, and there will be ear discharge um, that is that will be squamosal disease. It means the scanty discharge with foul smell, and there will be high grade fever, nausea, and vomiting due to raised intracranial pressure, headache, neck rigidity, photophobia, mental irritability, drowsiness, delirium, or coma seen in terminal stages. So there will be cranial nerve paralysis, third, fourth, fifth, sixth cranial nerve will be paralyzed, and there will be hemiplegia of the opposite side. And investigations are, you will do examination under microscope, CT, MRI, and lumbar puncture is done. Again, protein will be high and the sugar level will be low in the CSF. Treatment, you will treat the intracranial complication, then patient mastoid exploration will be done after treating the infection. So antibiotic is given, then with the help of neurosurgeon, craniotomy and burr hole craniotomy is done, and then later on mastoid exploration is done. So clinical features will include positive kerning sign, extension of the leg with when thigh flexed on the abdomen, patient will feel pain, and positive Brudzinski's sign when flexion of the neck causes flexion of the hip and knee. Then there will be exaggerated tendon reflexes, papillary edema due to raised intracranial pressure. So investigation will be CT, MRI, lumbar puncture, examination under microscope, culture sensitivity of the CSF is done. Then CSF will show increased protein and low sugar level. So treatment will be antibiotic, and in cases of acute suppurative otitis media, meningotomy and cortical mastoidectomy is done. Then mastoid exploration in cases of chronic suppurative otitis media. Then canal wall down procedures usually are performed. Autogenic abscess, that is cerebral abscesses, and cerebral abscesses are more common than the cerebellar abscesses. So temporal lobe abscess is the commonest abscess. So stages, that is your MCQ question, and stages of development of the abscesses are, there will be stage of invasion. It means initially there will be encephalitis. Then after inflammation, there will be enlargement of the involved area. Then there will be localization. This area will be localized by the fibrous tissue. Then there will be actual pus formation, that is stage of termination, and the pus will burst into the ventricles. So you can see in this diagram stage of invasion, then expansion, then localization, and then in terminal stages pus will burst into the ventricles. So pathogens are the same as seen in acute and chronic suppurative otitis media, streptoneumoniae, Staph aureus, Haemophilus. It's seen in the acute cases, and in chronic cases, Pseudomonas aeruginosa, anaerobes, proteus are usually seen in chronic cases. So symptoms in autogenic brain abscess will be due to raised intracranial pressure. There will be headache, projectile vomiting without nausea and vomiting. There will be loss of consciousness, papillary edema. That when you will perform fundoscopy, you will see papillary edema. Symptoms are due to symptoms will be related to the area of the brain affected. So, in nominal aphasia will be seen when there will be involvement of the frontal lobe. You will advise CT and MRI to see the site of involvement. Then lumbar puncture is done to see there will be protein will be high and sugar level will be low. Then treatment, again medical treatment, neurosurgical consultation, and after treatment of this brain abscess, you will advise mastoid exploration. So lateral sinus thrombosis are usually seen in acute, subacute, and chronic middle ear infections. So formation of the perisinus abscess, abscess formation around the sinus, it will lead to inflammation of the wall of the sinus, that is called end phlebitis. And end phlebitis will lead to thrombus formation inside the sinus. This thrombus will obliterate the sinus lumen, and then it will expand. Then extension of the thrombus will lead to involvement of the jugular vein. And then which bacteria are involved in this? Acute and chronic bacteria, Streptococcus pneumoniae, Staph aureus, Haemophilus in acute infection, then Pseudomonas aeruginosa, E. coli, and anaerobes in chronic infection. You can see in this case, first of all, there is perisinus abscess, then endophlebitis, inflammation of the wall of the sinus, then thrombus formation, and then this thrombus will expand. You can see extradural abscess in cases of involvement of the tegment tympani, and when the sinus plate is eroded, there will be formation of perisinus abscess. So lateral sinus thrombosis, in what investigation will you order? You will advise blood smear, blood cultures, CSF examination, culture and sensitivity of the pus, and CT and MRI to prove your diagnosis. Then complication will include septicemia, abscess in the lungs. These thrombus can part of the thrombus will dislodge and will go into the lung, causing lung abscess, bone joint, subcutaneous tissue abscess. Then subdural, it can lead to subdural abscess, cerebellar abscesses, and then meningitis. So patient will come to you with fever, rigor, history of ear infection. There will be headache, progressive anemia, and emaciation. It means anorexia, raised intracranial pressure, and symptom of raised in. You will see papilledema on fundoscopy. Tobey eye test will be positive. That is also called quicken stat test. You will check the intracranial pressure, and then you will check it after pressing the jugular vein. Usually in normal individuals this pressure will be increased, but if there is thrombus in the jugular vein there will be no change in the pressure. Then tenderness along the jugular vein, you will palpate the jugular vein, there will be tenderness. So treatment is again intravenous antibiotic. You will explore, mastoid exploration is done, and you will clear the sinus. You will clear the thrombus as far as when you will see the liquid blood. So ligation of internal jugular vein is done, anticoagulant should be given, and supportive therapy, it means you will treat the infection of the middle ear, and you will also give painkiller, antipyretic, and analgesics. Otitis hydrocephalus, usually mechanism is not known, but it is theoretically, if there is thrombosis of the lateral sinus, will increase the leading to thrombosis of superior petrosal and superior sagittal sinus and blockage of the CSF drainage. So there will be dilatation of ventricular system. Ventricles will be dilated and leading to formation of otitis hydrocephalus. So patient will come to you again with headache, fever, nausea, vomiting, diplopia, sixth nerve paralysis, then blurring of the vision, papilledema, and nystagmus. So lumbar puncture will be done, MRI will be advised, there will be raised intracranial pressure and dilatation, or all the ventricles will be dilated on MRI. Then you will reduce the CSF pressure by giving corticosteroid, acetazolamide, and repeated lumbar punctures are done to decrease the CSF pressure, or lumboperitoneal shunt can be kept. Again, antibiotic is given and the ear infection will be treated and mastoid will be explored. So now we come to our scenario. 20-year-old boy started losing weight and became anorexic, lethargic, having abnormal behavior for the last 2 months. His father said that he had foul smelling ear discharge for the last 5 years from both ears. Last year, he developed severe vertigo for 1 week and had been hospitalized. What is the most probable diagnosis? What was the cause of vertigo? And what are the otoscopic examinations? And what is the management plan? So as you see, there is history of chronic ear discharge and foul smelling, so etiquentral squamosal type, unsafe type. Patient previously had some vertigo, it means involvement, there is already involvement of the inner ear. Now patient has come to you with anorexia, lethargic and abnormal behavior indicating some intracranial complication. So this is our diagnosis. And what is the cause of vertigo? That is involvement of the inner ear. Otoscopic examination will show cholesteatoma or granulation in the attic region. And management plan, you will advise, as it is etiquentral disease, you will investigate, you will do examination under microscope, you will send pus for culture sensitivity, then you will advise CT, MRI, you will treat the intracranial complication, then you will do mastoid exploration. So all this is the management plan. So thank you.